what's happening is that, 20 or 30 years that I've been involved in spine surgery, this has continued to be a area of debate. And it's been said in the past, well, if you put a lift in, or if you do a T lift, or if you do things minimally invasive, then all the rules change. And what I'm going to show you is some of the rules I think are fairly immutable. These are my disclosures. And what's happening is that historically, for us to do fusions from L2 or above, ending at the sacrum, had a very high failure rate. It had failure rates due to loss of lordosis, the development of pseudoarthrosis, poor results due to pain, probably due to number one and number two, and many of these patients required additional surgery. Now, what's happening is there's been a variety of different papers through the years, and some people said, well, if you have good bone stock, or if you're able to restore coronal and sagittal alignment, if you don't have pelvic obliquity. But what has been shown is, as you add these things, you have even additionally higher failure rates. And even at a baseline rate, the results are unacceptably poor with longer fusions to the sacrum alone. And these are, again, other different studies looking at this failure rate between 22 and 89% when you stop at S1 for a longer fusion. And part of this is that biomechanically, the area of the sacrum is under tremendous stress. And what happens is this tremendous stress results in bone implant failure, implant breakage, loss of fixation, and again, all these things leading to pseudoarthrosis. And the greater the shear forces, the greater the axial load, for example, in substantially obese patients, the greater the cantilever force is by the amount of poor sagittal alignment, the greater the chance that failure is going to occur. So what's happening is the number of levels, the alignment, the bone quality, the instability go and give you from an unacceptable failure rate up to a catastrophic failure rate. Now, what happens is the sacrum itself has relatively poor bone. And you can see with aging that, particular in the area of the ala of the sacrum, there is substantial bone loss. And I think if you ever go and when you're looking at Hounsfield units, oftentimes for patients in their 60s, 70s, and 80s, the Hounsfield units will be in the teens in the area of the sacral ala. And part of this is the sacrum does not contain a true pedicle. It's a confluence of cancellous bone, and there's no good cortical ring to fixate pedicle screw fixation. So what's happening is this is the S1 quote unquote pedicle, which is this confluence of cancellous bone. And what you can see here is you're putting that bone through other areas of very poor bone quality. And some of these studies have shown that the anterior sacral cortex can be less than a millimeter thick, and even at the sacral promontory, the bone can be poor. And you can see that the promontory is probably the ideal place to place a screw, but even in most cases, particularly in the elderly, the fixation is inadequate. Now, one of the solutions that had been debated, 10 years ago was, look, do you really need to go to the sacrum? Can't we just stop at the L5 level and get rid of all of these sacral problems? And a number of different studies, and this one out of WashU showed that the failure rate, despite having a very healthy looking disc at the L5S1 segment, if you went over time, that the failure rates were unacceptably high. In this case, over half the patients ended up requiring a subsequent revision. So what's happening is that, again, fusing down to the sacral pelvis, does have disadvantages, including loss of motion, may have an effect on gait. But considering the failure rates and complication rates of the alternatives, it still remains to be the best choice. So basically, we look to fuse to the sacrum for cases of degenerative deformity, for high-grade spondylolisthesis, after resection and instability resulting from lumbar and sacral tumors, and in children with neuromuscular deformities. So generally, the sort of the general rules, and again, a little of this depends upon the other factors I discussed, that long fusions to the sacrum, L2 or above, usually require some type of spinopelvic fixation, high-grade spondylolisthesis, unstable sacral fractures, and reconstructions following sacrectomy are all indications. Now, people have talked about the use of interbody placement and how it reduces the strain on the S1 screw, which it does do, but the results, again, are such that biomechanically only iliac fixation, either traditional iliac fixation or S2-alar iliac fixation, gives enough support to prevent catastrophic failure under the most demanding of situations. This was brought to light by McCord, who introduced the concept of the pivot point and fixation extending anterior to this pivot point, which is the posterior aspect of the L5-S1 disc, is much more effective as far as forms of fixation, as you can see in the slide. So again, looking at a variety of different biomechanical studies, that if you're going to have a demanding fixation, generally the L2 level or above, some form of iliac fixation is needed. Now, for those people who are kind of a little bit slow, this should be the final confirming factor. And what's happening is, if you stop at the S1 level and you try to really push things, this is one of the sort of catastrophic complications that can occur. And you can see here, these are a variety of different sacral fractures that occurred with long fusions down to the sacrum alone. And for someone who, as you're going to see in a second, so all these are 9 cases that I personally revised after having them sent to me with sacral fractures, who initially had fixation stopping at the S1 level. And I'm just going to tell you that these are all painful to deal with. And if you deal with very many of them in the career, it'll teach you the advantage of spinopelvic fixation. So again, the results of fixation, either S2-alar or iliac, is exceptionally good. You're going to hear later on some of the evolution of the choices. And I do feel that for long fusions or high demand situations, some form of iliac fixation is needed. Thank you.
So give some tips and probes. Some of these we've already talked about in our discussion. So pre-op tips, again, I really like this spinal pelvic sagittal balance classification. Again, it kind of puts not only the slip into perspective, but the whole spine in alignment, which obviously makes, I think, a fair amount of sense. I'm still pretty aggressive, reducing even type 3s and 4s, but I found, again, as I mentioned, that a lot of these posturally reduce on their own. You're not putting a lot of active force on those to reduce them, versus the 5s and 6s, where you do have to more actively reduce the slip to reduce it. So this reduce or not reduce question, and how much is something that's still relevant today. That's why we put this session together. There's still some controversy about this around the world. The question to be safe, not too aggressive, but again, I think when I look at it, there's all these factors, slip degree and angle, and the lumbosacral pelvic parameters. Obviously, the global parameters ultimately are important to me. The residual thoracic and cervical malalignment that occurs in an imbalanced spine is huge, because, again, even in AIS patients, we try and recreate more normal thoracic kyphosis to have a better cervical and lumbar lordosis long term, which obviously will mean a lot to the patient in the rest of their life. And there's various patient factors. Obviously, neurodeficits, age, as I mentioned, age is a consideration, how aggressive we get, their posture, their complaints, obviously be a huge component to how we treat them. And I think experience as well. I'm certainly much more comfortable being a little more aggressive now than I was